and is weight loss important? And I'm really going to raise the question about, is there anything more than weight loss? My colleague will debate me later about this issue. Some disclosures. Okay, so the hypothesis regarding non-weight loss effects needs to be carefully defined. I'm going to show you several things. First of all, I'm going to show you that for type 2 diabetes, weight loss effect is overwhelming. The second thing I'm going to show you is that there's no evidence of a non-weight loss effect for the fundamentals of diabetes. That is, the long-term natural history of diabetes to date. I'm also going to indicate that there are a range of therapies that increase insulin secretion, and that those treatments include forms of bariatric surgery, but for all forms of increased insulin secretion, there are risks and benefits. So let me just, and some of these are repetitive studies, and you're going to see maybe a lot of repetition over the next few days, but that probably means it's important. The first study, these are 3 Asian studies. The first one is the one that's been presented already, indicating, this is from Professor Lee's work, his data, which is showing that the duration of diabetes, the C-peptide and the BMI are very important in this Asian population. But look at the effect of weight loss with gastric bypass surgery. Go on to look at this very interesting article in a small journal, our regional gastroenterology journal, of 403 gastric patients who had some form of gastrectomy for cancer or pre-cancer, which of course is very common in that region of the world. These are people who had diabetes, and they retrospectively looked at what happened to their diabetes. And the important thing here is that they listed all the types of procedures, whether it was Billroth 1, Billroth 2, Roux-Weiss, subtotal gastrectomy, total gastrectomy, da-da-da-da-da-da. But importantly, the average patient had a BMI of 24.7. This is the best data in the world, 400 and something patients. You'll see 24.7, and the average patient had a BMI of 22.2 at follow-up. So this seems like a small drop, but in fact it's 10% of body weight loss. This team showed very clearly that the way the stomach was repaired, the way things were put back together, had no influence on the remission of diabetes other than weight loss. And you'll see down there that worse, 6.8% weight loss, and those that went into remission, 14.4% weight loss. Have a look at this paper because it really comes from our region. It's very important. The authors went out looking for a method of repair that might affect diabetes. They were disappointed. They found that only one thing appeared to have an effect, and that was weight loss. They're very almost apologetic that they've found that in this study. So this is a very interesting study. Again, this from Wijay Lee and Dr. He from Korea, a very important study, because this is the largest study when a substantial number of patients have had gastric bypass with a BMI less than 30. 103 patients. And first of all, the remission in this study was 30%, not 60 as it was in the usual group with gastric bypass. And the typical predictors are identical, but have a look at weight loss. Have a look at the effect of weight loss. More so, this is a most important figure. This shows you, along the bottom here, not sure this will work, this is the initial BMI. These are people having gastric bypass. This is the weight loss. Notice the relationship between your BMI and having gastric bypass and the amount of weight you lose. It's an average of around 20% at BMI 30, and it's an average of 0 at BMI 20. No weight loss. Which is nice in a way. But look at the effect. The filled-in circles are those that go into remission. The improvements are the grey circles, and the open circles do not reach a hemoglobin A1C of 7. Many of them have improvement, though, and we mustn't discount improvement. However, the action is taking place, all the really good action is taking place with weight loss and in the higher BMI group. And if you put a line at about BMI 27.5, you'll see nearly the vast majority of patients who go into remission and improve are up in that category. And a lot of the empty circles are down lower. More importantly, all the actions taking place above a weight loss of around 10%. And it's important to recognise that aspect. But we did another analysis of this group, which is really interesting. What I did was to take the people who were predictably going to do really, really well. So based on our other predictors, BMI and duration of diabetes, we pulled out these groups and we found 28 people in the first group. And we looked at their percentage weight loss here and the hemoglobin A1C they achieved here. You will see that the extent of weight loss was entirely related to how their hemoglobin A1C came at the end of the study. And the relationship here, this is a 0.54 R squared. This one over here, which is based on the C-peptide and the duration of diabetes, it's actually over 6. Now, if you've got an R squared over 6, does anyone know what that means? It explains 60% of the variance. Every other factor known to man may make up the other 40%. So we have clear evidence here that weight loss is the dominant factor. Everything else is coming second best. So when we look at diabetes and we look at what drives it, we see insulin resistance and we see a deterioration of insulin secretion. What are the fundamentals? What happens with weight loss surgery with these fundamentals? Well, the first thing we see is what's happening early on. As already has been discussed, the lovely paper from Lim that shows with very low calorie diets the remarkable improvement and remission of type 2 diabetes within a very short time of using very low calorie diets. And it strips the fat out of the liver and it strips the fat out of the pancreas, insulin secretion improves, and all the abnormalities seen in bariatric, with all the improvement seen with gastric bypass is seen in this study. We see the second study, which was published in Diabetes Care. This was a very brave study done in the United States where they took people who were about to have gastric bypass surgery and they admitted them to hospital 3 months earlier and they gave them the same diet that they would have after bypass surgery, very low calorie diet. And then they studied them again, they put their weight back on, they studied it again when they did the bypass. What did they find at the end of that? Once they'd had the same weight loss, the same effects, these people, the same people, had no difference in insulin sensitivity, beta cell secretion, etc. No difference. And finally, a paper that's in JCI. Now, if you see a paper in JCI, in the molecular biology area, there isn't anything better. Gastric bypass and banding, exactly the same improvement in insulin sensitivity and beta cell function from this group in Washington State. But I'll talk more about that paper in a moment. So we go forward and we look at insulin sensitivity and we look at clamps done. And I'm going to focus on gastric bypass because this is the procedure that people are hanging their hat on. First of all, we see that the first study here, and I don't know that you can read the date on this, but highly significant improvement in insulin sensitivity, long-term after again, gastric bypass, compared with duodenal ileal bypass. Is that right? This paper, which did clamp studies, was published in 1984. And you know what it showed? No difference between the gastroplasty and the duodenal ileal bypass as far as insulin sensitivity was concerned. Oh dear. And then we had a lovely paper from Dr. Mingroni, and it was actually done in Brazil with gastric bypass, insulin sensitivity improvement, total body insulin sensitivity improved in relation to weight loss. Study after study has shown that. But hepatic insulin sensitivity improves quickly with any weight loss, with any restriction. And then finally, a little bit more about that paper from the Washington University of Washington group. In morbidly obese patients, Roux-Y has a metabolic effect on the liver, adipose tissue, muscle, insulin sensitivity, and substrate. And the effect of those, the first effect is that the short-term effect is related to a reduced energy intake, same as the low-calorie diet study. And the dominant effect in the long term is a thing called weight loss. Now, what about improved beta cell function? Well, we measure it by secretion. And we can belt anything to belt the pancreas into secretion. What we're missing in this whole thing is what's happening to beta cell mass. And the important thing with beta cell mass is we see here a normal pancreas, a normal pancreatic islet. We see here a hyperplastic one in obesity. And down the bottom, this problematic islet where the beta cells, alpha cells are small, they're degenerate, and 60% of the mass is gone before diabetes is even diagnosed. And we can see here's the beta cell mass at the top here, and the major problem is beta cell apoptosis. That's what we want to. If we want to cure diabetes, we're going to have to fix this. Now, what happens to your beta cell mass throughout life? It decreases throughout life. It decreases with a number of genetic disorders, and it decreases with a number of toxins. And the toxins that cause the most of the trouble are lipotoxicity, glucotoxicity, and the inflammatory markers of obesity. That's why you get this rapid beta cell deterioration. And the best treatment for that is weight loss. It will improve all of those factors. And we're unsure as to whether any form of metabolic surgery is better than any other at doing that. And of course, people's deterioration is bad with type 2 diabetes. So with metabolic surgery, weight loss reverses the metabolic effect. We don't know that anything more occurs. We have no evidence in humans that we can reverse the process and lead to an improvement or even stop the reduction of beta cell mass deterioration with bariatric surgery or metabolic surgery. This is a dream that we're going to do this, but dreams can become realities, and we hope. But that would be a dream for a cure of diabetes. Beta cell secretion, all procedures with weight loss, the requirements for insulin fall over time. Type 2 diabetes is going to improve if there's adequate secretion. Type 2 diabetes, if you've got a secretory effect from GLP-1 agonists, of course you will have improvement. And of course insulin therapy does the same thing. Walter Porres preaches against insulin. He says insulin's the poison of the body, and it's the poison that drives diabetes. So he wouldn't be looking at insulin secretion as being a great advantage. But let me say, incretins, whenever they occur with type 2 diabetes, Roux-Y gastric bypass, anyway, there's a problem. But we've got to think, is there something beyond that? Now, the classic paper for incretins comes from this paper from, I think this is one of the early ones, many people have shown it. This is from Blandine-Lafayette. And the thing about this study is that remarkable improvement in incretin effect. The area between those curves is very, very important. But what I look at this slide and I say, what's it really telling me? Well, you often say, look at the bottom line. What's happened to the bottom line, the intravenous effect on glucose tolerance? Nothing. In fact, it might be the insulin secretion with intravenous glucose has in fact gone down. Nothing's really happened. This is a gut effect. This is an incretin effect. And of course, here she shows the GLP-1 going up, L-cell stimulation. Here you'll see the incretin effect can be completely blocked by using a GLP-1 antagonist, Exendin 936. In type 2 diabetics, in non-diabetics, the problem with GLP-1 and incretin effect is that if you've got that the hyperplasia of your beta cells, we may be actually driving dumping that is worse, and of course neuroglycopenia in these patients having problems with passing out with hypoglycemia. Importantly, we'll come back to that JCI paper, the band, in fact, band and bypass, large postprandial increases in glucose were occurring with glucagon-like peptide, GLP-1. However, this was an abnormal glucose tolerance test that was occurring because it was producing that. Now, indeed, we go on and we look at this study, and they showed with the people losing exactly the same weight loss, oral glucose tolerance, insulin sensitivity, beta cell function, after weight loss was no difference between these procedures. And I think we've got to be very careful because GLP-1 can be problematic. And if you've looked at the press lately, there's a lot on this. Concerns about GLP-1 stimulation of the pancreas, acute pancreatitis, pancreatic cancer, thyroid function. The ADA have asked drug companies to provide their best data, and the FDA only just last month have reassured people, don't panic about GLP-1 stimulation. We hope it's going to be all right. But finally, this is my final bit of data. If we look at these procedures in the long term, SOS study, and we look at this large multi-centre study, which is by far the largest, of 4,000 patients with diabetes, and the SOS study, you know, VBG, fixed bands, bypass with the dominant procedures, 72% remission at 2 years, 36%, half by 10 years, mean duration of those who went into remission was 10 years, large multi-centre study from the United States, 4,000 patients, 68% of remission before 5 years. At any time there was 68% remission. 35% had redeveloped diabetes by 5 years, and the duration of diabetes remission, 8.3%. Lower than the Swedish obese subject study. In other words, we're getting 8 to 10 years out of people, whatever we do. Conclusion, the evidence for weight loss is the main effect is overwhelming. There's no evidence beyond a weight loss effect on insulin resistance. The early effects are hepatic and longer-term effects, total body insulin resistance. There's no evidence of a beyond weight loss effect on beta cell mass. That's what we're looking for a cure. And insulin secretory agents, and including insulin therapy, can improve diabetes and improve glycemic control, but don't have a long-term effect on long-term disease. So if you ask an Australian what's the real benefit of weight loss, is there a benefit beyond weight loss? And I'd have to say you're living in cloud cuckoo land. There's no evidence for it. But let's have a look at Dickens. Dickens says, maybe one day we'll find a place where our dreams and reality collide. And I can tell you that Ricardo looks at that apple and it's complete and it's ready to eat. And he's one of many, which I think is fantastic, because his dreams, we can always defeat reality if you give it a chance and you keep looking and looking. And I'm hopeful that people like Ricardo and many others in this area are going to find a secret that is beyond weight loss. But at the moment, we're still struggling. Thank you.
Thank you. Thank you, Professor John Dixon. I'd like to invite Dr. Ricardo Cohen to give us the talk about the weight-independent result of metabolic syndrome.
Good morning, everyone. Thank you, Mufi, for the invitation, and Aparna for the invitation. And it's funny and interesting to have such a debate with John and most of people that do not believe. Actually, John believes, but he's playing his role. And I'm going to show some interesting data that it's not recognizing. Okay, they take this place. Let me detect. Hold on a second. It's not detecting. It's not detecting. The display changes here. Do you have a USB disk? Because there's something wrong with it. Yeah, I'm losing. No, yes. Now it's, you have to change. Now it's detecting. I'm going to win. Okay. 5 minutes. No, he had 15, I'll have 15 as well. Those are my disclosures. And how does the gastric bypass or gastrointestinal bypass operation can cause remission of diabetes? I agree with John that weight loss is the main thing. And this is the weight loss in the thousands of times repeated SOS trial with 20 years follow-up with a mixed set of operations. And diabetes remissions is really durable. And I agree that the increasing insulin sensitivity with weight loss, it's undoubtedly a major thing in this field. But it's too fast and durable to be credited to weight loss alone and calorie restriction alone. What Sam Klein, the paper he showed with the band and insulin sensitivity improvement, was in non-diabetic patients. So how can I prove a non-diabetic patient improving his glycemic parameters? So although Sam Klein, we collaborate together always, he's a good friend, but he's misleading. Look at the Lean Diabetologia paper. It's interesting, how long can we sustain an 800 calorie diet? 8 weeks probably is good. But if you all remember the Allen diet for type 1 diabetes back in the 1999, 1920, insulin was discovered in 1921 by an orthopedic surgeon, again, surgeons saving the world, called Banting. So the Allen diet for type 1 diabetes was necessary because there was no insulin, but there was 95% of mortality in a 600 to 800 calorie diet per day. So I think, yes, we can simulate the effects of any gastrointestinal bypass operation or any metabolic procedure with weight loss, but with calorie restriction. But again, it's 8 weeks. That's the most that they can prove. Look at Dr. Pori's interesting report. The patient was taking 19 units of insulin. This is back in 1980, 1978, 1979. 0 insulin by the 28th day after surgery. This is a paper by Phil Schauer in the Annals of Surgery 2003. Well, most of the patients were resolved, he means control fasting and post-prandial glycemia by 48 hours. It's okay. Probably it's calorie restriction. But the fast kinetics of diabetic resolution doesn't match our results because we have glucose homeostasis improvement more with bypass operations than other means of weight loss. Let me show you some examples. This is Carol LaRue's paper comparing long-term follow-up of gastric bypass versus gastric banding regarding diabetes remission. And he stopped at the same weight loss, the study, and he analyzed the results of diabetes. It's much, much lower in the bypass than in the band. So it's a mean of weight loss, the same weight loss. There's something special behind gastric bypass. Again, François Patou from France, he took patients, obese patients, he included bands and bypass, and he stopped at 10% weight loss. And he studied in a non-randomized fashion, prospective study, A1C, HOMA, mixed meal challenge, and incretins. What's interesting that at 10% of weight loss in both groups, so weight loss is consistent and similar in both groups. Look at the percentages of glucose control versus the bypass versus gastric banding. So again, weight loss is important, but how much important? And I have no time to discuss about the look ahead study that was presented at the ADA 2 weeks ago and was published in the New England Journal. Weight loss was important, but cardiovascular deaths were not affected. So again, weight loss may be important, but they don't change at all the events and mortality on diabetic patients regarding cardiovascular events and deaths. This is Blondine Laferrere paper against the same thing, type 2 diabetes. I think John showed, I'll go very quickly here. She matched for BMI, age, degree of intensity of diabetes, gastric bypass and diet, studied the same weight loss. Again, look at the mixed meal challenge. Before Roux-en-Y gastric bypass, before diet, they're the same. After diet, still peaking. It flattens after gastric bypass. Again, there's something going on. Dr. Lee's paper, it's a repetition. I agree with John. It should be important because we repeat this every time. At the same weight loss, non-significant. Looked at the diabetes resolution comparing patients with food rerouting through the GI tract versus a pure sleeve gastrectomy. We did a collaboration with a Spanish group where we did the gastric bypass part and we did the sleeve gastrectomy. And at the same BMI post-op, at the 3rd month, insulin resistance was decreased in the gastric bypass, was better insulin sensitivity in the gastric bypass than sleeve gastrectomy at the same BMI. So again, there's something going on behind this. Let's look at other papers that studies diabetic patients with cancer that were analyzed. This is Walter Porter's group. They published a meta-analysis about the amelioration of requirement of insulin in patients undergoing duodenal bypass surgery for whatever reason. Cancer was the main. And look at the conclusions. That's different than the paper that John showed. 33% of diabetes resolution and 70% of improvement in patients regardless of their pre-op BMI and weight loss. Another study, the same thing. They compare diabetes resolution and the type of reconstruction after gastrectomy for cancer. Again, the duodenal bypass group had higher diabetes remission and improvement than the B1, the BROTH1 patients, regardless of pre-op BMI and weight loss. So I believe, and I'm sure that I'm not only dreaming, there's something else than weight loss. There's this inconsistent correlation between the amount of weight loss and diabetes remission after Roux-en-Y gastric bypass. Again, this is the very nice and elegant Lars Sjöström graph, and I don't have time to go after this, but there's several publications and several multivariate analyses of the 20-year data showing additional benefit of surgery, even diabetes prevention beyond weight loss that improve diabetes. If you're familiar with those papers, the only pre-op determinant of cardiovascular death was not pre-op BMI or weight loss, was fasting insulin levels. And that was repeated by another study, 2 studies by the same German group on malignant obesity. So there's something very interesting. Pre-op BMI does not predict at all diabetes prevention or remission in the SOS. And okay, heavier patients lost more weight, but this didn't make any difference between the pre-op BMI and diabetes remission. I'll go very quick with our study. I'll present this in the afternoon. We had 88% of remission in patients 30 to 35 Caucasians. They're different than the Asians. Remission was A1C below 6.5 without any medications. Very nice decrease in A1C, very nice decrease in fasting glucose, and this is what I want to show. There's absolutely a lack of correlation between weight loss and improved glycemia. Because look at this. At 5 and 6 years, there's a statistical artifact, but all diabetes remission occurred by the 6 months. So I don't care about this because most of the patients were remitted at 6 months. So statistically, we don't have any relation between weight loss and diabetes remission. So, and some intestinal bypass operation improved diabetes with little or no weight loss or even some slight weight gain. And those are the novel procedures as the duodenal bypass with the intact stomach or the endoscopic duodenal bypass liner. And this is what we did with the DJB with the intact stomach. And this was in collaboration with Sam. Look at this, the mean pre-op BMI. I'm not advocating on doing surgery in patients with BMI below 30 in our Caucasian population. This was a randomized, this was a trial under IRB control. So we had 7% of weight loss, but most patients returned to baseline weight at 12 months, and even 5 on 35 patients gain weight if we compare to baseline. We had 20% of all patients with medication, free of medication with A1C below 6.5 at 12 months, and a significant decrease in medication score at 6 and 12 months. And it's interesting that we compared that group with a normal glucose tolerant group. And we showed with a minimal analysis, those are math models of C-peptide secretion versus insulin resistance, insulin secretion rate, and all indices of responsiveness to glucose increased 2 to 3-fold after DJB. So we're not like normal glucose-tolerant patients, but yes, we increase beta cell function. And again, I don't have time to go further with this, but we haven't any prediction factor. BMI was not a predictive factor. Pre-op C-peptide was not at all a predictive factor. So we have something going on with the dream coming true. We had beta cell function being improved. And in our DJB group, again, like the gastric bypass group, but with lower BMIs, we have the R square here is 0. We have no relation in the delta A1C with the delta BMI. So the weight loss or weight gain did not influence at all A1C drop from baseline to 12 months. We published a case report where we had diabetes remission without weight loss in a patient that had a B1 distal gastrectomy, and she was reoperated due to alkaline reflux to the stomach. And we converted it into a Roux-en-Y gastric bypass. And with virtually no weight loss, that patient was with A1C 7.5. Diabetes were not the goal of the revisional surgery. It was the bile alkaline reflux. And at 2 years, we had A1C 5.9 without medication, without weight loss. Again, there's something going on. We did the first duodenal jejunal bypass liner in low BMIs. It was published twice, two different papers at JCM and Diabetic Medicine this year. This is the way the study was designed. The mean BMI was 30, and the mean duration of diabetes was 6.5 years. And we had 62.5 patients with A1C below 7. We had 4 non-responders. 16 patients is a very small cohort, but 4 non-responders contaminated our numbers. But look at this, 62.5% of subjects with A1C below 7. There's no relation there's no decrease in BMI in those patients, not at all. The BMI keeps with no statistical difference between pre-op and 1 year. Again, it's the same beautiful graph that we saw in the DJB. There's a lack of correlation of weight gain or weight loss and A1C. The R squares here is 0.0 something. Again, there's no correlation. And we have some hints of hyperinsulinemia in those patients. And this was published by Service back in 2005 about nocidiolastosis. There's something that this really not consistent with the reports, but we have some too much of a good thing. We had some islets hyperinsulinemia with hypoglycemia that was never found before. And we have some evidence, animal evidence, of increased beta cell mass after intestinal bypass operations. Those are the publications, like the beta cell area for transposition, some GK rats with regeneration of beta cells, neogenesis of beta cell area after gastric bypass. So we had a lot of learn. So what causes gastrointestinal food rerouting, weight loss independent, anti-diabetes effects? There's a lot of things. GLP-1, incretins, amylin, duodenal factor that we're going to show in the next debate about mechanisms, intestinal modifications, intestinal gluconeogenesis, the increase of bile acids. That's something very an upcoming area of interest with the gut microbiota, the decrease in ceramides levels, and tons of things going beyond weight loss. But we have a lot to learn. What's very exciting in this area is the more we learn, the less we know. And John, I'm sorry, but I'm a dreamer, and there's much more else going besides weight loss. Thank you.
Thank you, Dr. Ricardo. Actually, we're going to start our next debate, the demystifying metabolic surgery. Will be also being presented by Dr. Ricardo.
There's no debate. I won. I'll keep on going with the foregone mechanism and diabetes resolution. More than just weight loss, I will reaffirm my dreamer state. Well, all began with Francesco here. He's a real dreamer. You should agree with me, John, that Francesco is the real dreamer. And he's a rat king. And with his animal studies, all began. He defined what we call today the proximal intestine mechanism. And he still believes, and there's some clues that probably he may be right, that there's some duodenal factor that or a foregut factor that enhances the anti-incretin effect. What he claims is that there's something going on to stop the incretin effect after a meal. Otherwise, all of the people here in this audience will be dead after a meal because nothing will stop the incretin action and all mechanisms to improve the glucose going into the cell. So he claims that in diabetic patients, there's a duodenal factor that will break this balance between the incretin and anti-incretin effect, favoring the anti-incretin mechanism. And he did a very, very classic and very elegant study where his two groups, duodenal exclusion as we did in humans following this paper, and a gastrojejunostomy group. What he did is this. What he did is, in red here, the duodenal bypass, a total foregut exclusion, and here a gastrojejunostomy, where the food goes to the duodenum and foregut and to the gastrojean anastomosis. And this is the oral glucose tolerance test, where the rats with the duodenal bypass, the pure foregut exclusion, has a flatter curve of glucose levels. So he showed that when we exclude the foregut, yes, you achieve a better glycemic control. And he went on with the gastrojejunostomy group. He transformed the gastrojejunostomy in a pure duodenal bypass. So he transformed this into a duodenal exclusion. And look at what nice. When the rats with the gastrojean anastomosis, with food going through the foregut and through the distal gut, they had a higher area under the curve glucose values. When he converted this into a pure duodenal bypass, look what nice, the area under the curve of glucose went down. Almost 10 years after, several experiments were published showing the importance of weight loss and incretin-independent anti-diabetic effect of the foregut exclusion. And some animal findings were supported by human findings that my group and several other groups in the world just replicated. Breen, she works with a Canadian basic researcher with Tony Lamb. She showed that there's a glucose-lowering effect of duodenal bypass that is weight and insulin independent. What she showed that that after the DJB, there's when she infused nutrients into the jejunum, she lowered the glucose production in normal rats and diabetic rats to a complex network of brain, hepatic, and gut network. So there's something that goes on when you exclude the proximal bowel, the food goes to the distal bowel, it gives a sign to the liver to stop producing glucose. And this was reproduced by us in the duodenal bypass liner study that I showed you. Look what interesting. Immediately, 1 week after the endobarrier, HOMA-IR, that's a marker of hepatic insulin resistance, decreased. And after 1 week as well, and this lasted, the HOMA decreased and the Matsuda index increase lasted for 52 weeks was the duration of the trial. So yes, there is a decrease of hepatic insulin resistance and an improvement of insulin sensitivity immediately after the operation. So probably Dr. Breen and Tony Lamb, they're right. There's something going on with the foregut. And again, the body mass index haven't changed at all. And in our duodenal bypass, again, I'll show you again the same thing. 5 gain weight, and still we have 20% medication-free with A1C below 6.5, and 40% A1C with A1C below 6.5, then with less medication than baseline. And those are not modest numbers. If you go to morbidly obese patients and you define what's remission, A1C below 6.5, not 7, you'll find barely the same results. So if the patient is insulin resistant, besides his BMI, he'll have the same results with food diverting operations aiming diabetes resolution. Zhao, 2012 and 2013, from July to July, it was a golden year for basic research in the foregut theory of diabetes resolution after metabolic surgery. Zhao proved that the DJB alone ameliorates glucose intolerance independent again of body weight and augmented insulin secretion. restores hepatic glucose production, exactly the same thing that Breen showed back in July 2012. And peripheral and insulin sensitivity improved, the same that we showed in our endobarrier patients, and decreases lipogenesis. So patients get out of the glucotoxic and lipotoxic effect. And again, duodenal bypass ameliorates obesity-induced glucose intolerance and hyperinsulinemia independent of weight loss. There's other basic science that supports our theories of weight loss independent effects of food rerouting through the GI tract. The anti-incretin theory that's championed by Francesco. So he claims again that there's an imbalance of the anti-incretin versus the incretin effect in the diabetic patients. So the anti-incretin might act as a diabetogenic factor if enhanced by food-borne stimuli. And the group of Geltrude Mingroni with a German group and Australia, it's an international group, Paul Zimmet from Australia, Vidal from Germany. It's not Vidal from Barcelona, but for Germany. And Geltrude Mingroni, they did a very elegant study that was published in PLOS ONE. It's an open access journal on March this year. They took proteins from the duodenum and jejunum of diabetic mice, the DBDB mice, and she used in normal mice soleus muscle of rats. She infused in skeletal muscle cells, and insulin resistance was developed in vitro. It's very interesting. She took proteins of diabetic mice and she infused in normal muscle cells of normal mice, and insulin resistance was in vitro increased. She took the same proteins from the sick mice and infused in a normal Swiss mice, and insulin sensitivity was reduced. So there's the first hint of a duodenal factor. She removed proteins from a sick animal and she infused in normal muscle in vitro and to normal rats in vivo, and she reproduced insulin resistance that happened in the sick mice. And she went on. She took proteins from insulin-resistant jejunal humans and the blood serum from insulin-resistant humans, and she infused in human myotubes, and again, impaired muscle insulin signaling happened. So there's the hint, a clue for insulin resistance in vitro and in vivo that comes from sick insulin-resistant humans as well. Let's compare to the sleeve gastrectomy. Is there something special going on? We know there's excellent clinical efficacy, change in hormones, probably similar to Roux-en-Y gastric bypass. And what's interesting, that the effects of the sleeve gastrectomy were not abolished. Were not abolished when GLP-1 receptors were knocked out in mice, but they were abolished when the bile acid receptors were knocked out. So this was published by Randy Seeley group in 2-3 months ago. As I told you, 2012 and 2013 is a golden age for basic research in the foregut hypothesis. And it's very interesting that, again, although there's high peaks of hormones, when you block them, you do not abolish the effects of the sleeve gastrectomy. And the injection of GLP, I think John showed this, the injection of GLP-1 antagonist does not entirely reverse the improvement of diabetes in humans who had Roux-en-Y gastric bypass. So again, hormones are important, but they're not protagonists, they're not the key players. It's interesting that DJB improves glucose tolerance more than sleeve gastrectomy by weight independent in Zucker diabetic fat rats. Look, it's nice. This is sleeve gastrectomy rats and sleeve gastrectomy pair fed. Yes, they're more weight loss, but the glucose effect is much more important in the DJB. The area under the curve of glucose is much more important in the DJB rats when we compare to the rats that had more weight loss with the sleeve gastrectomy. So weight loss is important, but not that important. This is the Phil Showers paper when actually previous speakers showed that 42 remission after gastric bypass versus 37 remission after the sleeve gastrectomy. It's interesting that there's a trend of higher fasting plasma glucose on the sleeve gastrectomy group. Probably there's a lack of intestinal signaling in those patients. But let's read very carefully this paper. After 12 months, it was a similar number of remissions, but the Roux-en-Y gastric bypass had 3 times less medication than the sleeve arm. So they're different, of course they're different. Sleeve gastrectomy, it's a good tool, but it's not as effective as the gastric bypass. Phil went on with the papers. He selected the 2 years follow-up with mean BMI of 36, severe diabetes. He went on the Stampede follow-up, gastric bypass versus the sleeve versus intensive medical treatment. Look how nice is this table. Roux-en-Y gastric bypass and sleeve, A1C is probably similar. Intensive medical arm loses the battle against surgery. BMI, it's similar, lower than the intensive medical group, but insulin sensitivity, it's 3 times improving in Roux-en-Y gastric group. Same weight loss. Again, there's something else going on than weight loss. It's unchanged in the sleeve and medical treatment. The beta cell function measured through a minimal model of oral disposition index is 6 times greater in the Roux-en-Y gastric bypass at 2 years, unchanged in the other 2 groups. And what's very important, the truncal fat, the visceral fat is decreased with significant statistical significance in the Roux-en-Y group rather than sleeve gastrectomy. So similar weight loss, but much more side effects and good side effects in the Roux-en-Y gastric bypass group besides of weight loss. And let's challenge the theory that GLP-1 is secreted by distal bowel stimulation, as the ileal transposition should be defended through. This is a paper that the slides were given by Francesco, and it was accepted for publication in the Obesity Journal, not Obesity Surgery, Obesity Journal. I think it's online already. So this is the acetaminophen test of gastric emptying. And gastric emptying is improved, it's swifter with sleeve gastrectomy when you compare the duodenal bypass and ab libitum fed animals. So it's interesting what he did. He infused food in the stomach without any mechanical clamp in the GI tract of mice. He infused food in the stomach, clamping the duodenum. He infused food, clamping the pylorus and infusing into the duodenum. And he infused food in the distal bowel. So the interesting thing is the stimulation was gastric and decreasing through the GI tract because there was no clamp. This is only in the stomach, mostly in the duodenum, and mostly in the distal bowel. Look what's interesting. GLP-1 response, it's much more important when you infuse food into the duodenum. In this group, when you clamp, you just infuse food and measures the postprandial levels of GLP-1 into the duodenum. And compared with the distal jejunum, there's a huge statistical advantage over the GLP-1 response in the duodenal infusion. And again, what he did, he infused mixed meal into the duodenum and clamped the pylorus and 8 or 7 centimeters distally. It's a mice model. Again, only the duodenum was stimulated, and here in the stomach, all the GI tract was stimulated with food. Again, the GLP-1 response in the double clamp group is much more important than the control group where the food was infused here. So we can observe here that the GLP-1 response is much more important when you infuse food into the proximal bowel. And this is what we found in humans. Our GLP-1 response after DJB, after sleeve DJB, it's not statistically significant. And patients had remission without insulin peaking. So the Heidegger hypothesis that we will be defended by another speaker that will follow me, it's challenged because we don't need to have undigested food in the distal bowel to have incretins to be released. So there's something going on with the proximal bowel. And I took this data from Aureo de Paula. He's from Brazil as well. He's the champion of the ileal transposition. He was at least the champion of ileal transposition. And he did a randomized controlled trial aiming showing the results of his ileal transposition in diabetic patients. And he compared ileal transposition plus sleeve gastrectomy versus ileal transposition, sleeve gastrectomy, and duodenal exclusion. So he compared this form with duodenal exclusion, with ileal transposition with the sleeve, without duodenal exclusion. He was not aiming to prove anything, but he proved that when you divert food from the proximal bowel, you get much better glycemic response. So the only variable was excluding the proximal bowel. And he showed that, yes, excluding the proximal bowel, we add much better results in the ileal transposition pure with a sleeve gastrectomy. How does this work? I don't know. Well, this is, again, all that we know is that we know nothing. Probably there are paracrine mechanisms. I believe in changes gut microbiota. We're running a randomized control trial in sleeve DJB versus medical treatment. And one of the factors is a radical immediate change of gut microbiota in patients that achieve early remission by the 3rd month. There's important alteration in secondary bile acids into the bloodstream. Yes, there is a nutrient sensing mechanism going on with the proximal bowel, as all of the papers showed. And the anti-incretin, with the first clue, was published by Mengroni's group. And I'm sure there are others mechanisms going on beyond those here listed. In conclusion, I believe that the foregut theory is the foregut mechanism, not a theory anymore. Bypassing the proximal bowel has weight-independent anti-diabetic effects. There are direct and distinct mechanisms of action in glucose homeostasis, independent of insulin secretion and independent of weight changes. GLP-1 enhanced secretion cannot, it's not the major key player, and I believe in altering the food tract is a major thing regarding diabetes resolution, and it has a powerful effect on glucose homeostasis, but the mechanisms are elusive. I'm sure there are several different mechanisms going on beyond weight loss. Thank you.
Thank you, Dr. Ricardo Cohen, for the nice presentation. Unfortunately, our next speaker couldn't make it because he developed late-night muscle spasm. I think he may have more explanation for this late-night muscle spasm. Let us ask him later. Thanks, Dr. Bouza, for presenting on behalf of him. So he will present for us hindgut theory. We'll see. Thank you.
Very much. Thank you very much, Mufi, for the invitation. And I just arrived after a 24-hour flight. So, but just only because I like to fight against Brazilians, and especially Ricardo. That's why I accepted to do this debate in the last 15 minutes. So, I apologize for my slides because I prepared it just when I was looking for the usual slides Ricardo always present. The only thing I want to say about the hindgut is that it's totally different to speak about weight-independent factors than stimulating the distal bowel. And I think that's probably the main difference of the hindgut versus the foregut theory. Everybody knows all of the hormones that we already know, PYY, GLP-1, definitely after gastric bypass they rise. Also, we've seen that in gastric bypass and also in sleeve gastrectomy in the same format, but in a less intensity. So definitely sleeve gastrectomy has the same effect or a similar effect than gastric bypass, but in a less intensity. GLP-1, we saw the same things on these patients, and we saw all these papers that definitely GLP-1 in gastric bypass rises on a level similar to sleeve, but the sleeve doesn't peak the same. So basically, what happens? Everybody hates now GLP-1 because it's like the ugly of the party because nobody wants it. But at this point, still GLP-1 is the best explanation we have, and we're still looking for the Rubino factor or factors that we are looking for about the foregut and the hindgut. We started doing many studies several years ago. And we wanted to say well, can we achieve the same results without bypassing the proximal bowel? And we started doing some animals with just by the time Dr. De Paula started doing this in patients, and we started doing, and what we saw was that if we saw the sham animals, and we found that the ileal transposition, the animals had weight loss and similar weight progression, and when we did sleeve gastrectomy plus ileal transposition, we had a very good weight loss that was very similar to gastric bypass. So we couldn't find any difference between sleeve gastrectomy plus ileal interposition plus compared to gastric bypass. So we didn't find difference in terms of weight loss, not bypassing the proximal gut. We found that there was a difference in fat absorption and mineral absorption. In gastric bypass, there was more mineral malabsorption and not in the ileal interposition, also with our minerals. So, and again, GLP-1 was in the sham animals was like this, in the ileal interposition was higher, and in gastric bypass was similar to ileal interposition, but in sleeve gastrectomy plus ileal interposition was the highest peak of GLP-1. Again, probably there are many other explanations, but still GLP-1 is the #1 hormone we have, is the #1 hormone used for the treatment of diabetes, so we shouldn't say GLP-1 is not important. Maybe there are some other factors, but GLP-1 definitely has a role in controlling diabetes, and we don't need to bypass the proximal bowel to achieve high levels of GLP-1. In this study in rats we did also, we found that the same baseline in terms of percentage of weight, we found the same things in ileal interposition compared to gastric bypass. And also we found differences, and we found very similar glucose curves after ileal interposition compared to gastric bypass. So basically what we did is that we achieved a very similar glucose curve without bypassing the proximal gut. And this interesting study also from Asia, they found here, this is the glucose tolerance test of sham animals and control animals, and when they did ileal interposition and mid-duodenal jejunal bypass, they found exactly the same effect, basically without bypassing any of the proximal bowel. And also, when we found GLP-1 levels, they found a similar thing, ileal interposition compared to sham and mid-duodenal jejunal bypass. They found that it was not as good as ileal interposition for achieving high levels of GLP-1. And here's the intestinal adaptation. Ricardo said about, for instance, endobarrier. Endobarrier can achieve, you are excluding, but maybe you are not excluding. You might be excluding a 60 centimeter of bowel with the endobarrier. But what's happening there is that you're stimulating early, because you are making the food arrive early to distal parts of the bowel. And in this nice study, before surgery and after surgery with ileal interposition, you see how impressive the intestinal adaptation after the interposition, the increased bile recirculation here. So probably the distal gut has a lot to do in all of these differences in recirculation, in bile acids, and especially also in what's happening in terms of weight loss. And with the patients of Dr. De Paula, he found, and I totally agree with Ricardo, that he did ileal interposition, but then he did some kind of diverted form of ileal interposition. However, with ileal interposition patients, they found a very, very good results in terms of diabetes control. A1C dropped down very dramatically. 87.5% of the patients had a resolution when they had diabetes for 3 to 5 years. Diabetes control was really very, very good, with improvements of A1C very significant. However, what's the difference between a diverted ileal interposition or duodenal switch, basically probably is the same thing. We reinvent the wheel, and I think Michelle has always been very active in trying to say that basically ileal interposition plus sleeve gastrectomy is basically another duodenal switch. When Francesco and Ricardo started doing duodenal jejunal bypass, they had to add the sleeve gastrectomy, so they end up transforming this in a short duodenal switch. So basically, and we see which is the long-term control of type 2 diabetes after biliopancreatic diversion. This is what we see happening. This is the best operation to control diabetes. And can we say that this is because we are bypassing the proximal? What's the main thing about biliopancreatic diversion is not that you bypass the proximal gut, it's that you overstimulate the distal gut. And that's probably the main difference, because you can do a usual bypass. And to finish, just to tell, when we see which is the final numbers of different procedures in bariatric surgery, we see that any form of duodenal switch or bypass, or the complicated duodenal switch or biliopancreatic diversions, are only 1 or 2% of the bariatric practice. So probably you will never pretend to do biliopancreatic diversions or duodenal switch to treat diabetes. So in conclusion, we're still waiting for the Rubino factor, and maybe if we find it first and we still time, we can put it the Cohen factor, and we'll find it. So thank you very much.
Thanks, Dr. Bouza, for the nice presentation. We would like to invite again Professor John Dixon for the spinal